I call upon Dr. Laxmikanth sir. He's our own star who put Mysore in national stage. He's organized South Zone Critical Care Conference in Mysore. He's also faculty at various state and national critical care and anesthesia conferences. He is a known faculty at FCCS critical care programs. He is the director of IMPACT, that is ICU management programs and clinical training academy, which has brought a lot of improvement in Mysore in terms of critical care for patient management. He is a teacher in critical care medicine in ISCCM and RGHS. He has many publications to his name. His core skills are managing closed ICUs and difficult airway management, sepsis management, neuromuscular monitoring, cardiovascular monitoring. Over to you, sir. Thank you.
Thank you, Suma, for the generous introduction. Akshay probably has taken away the highlight of the day from academics to the investment part. Of course, it's also one of the neglected part of our practice. It's good that this topic was introduced. Coming back to medicine again. So we'll be dealing with upper GI bleed, primarily the non-varical because of the limitation of the time here. Coming to the causes, like if you see about varices constitute about just about 8% of the total GI bleeds we see. So predominantly it's a non-varical bleeds we practice. Okay. Can we differentiate bleeds clinically? Yeah. With some clinical hints, we can assume a probability of origin of bleed when the patient comes to us, like peptic ulcer coming with a upper abdominal pain. Esophageal ulcer can have adenophagia, gastroesophageal reflux, dysphagia. Malarious tear, obviously there will be a retching, vomiting. And varicose hemorrhage will have a history of a chronic liver disease or a portal hypertension. And malignancy, of course, will have enough clinical clues to suspect a underlying malignancy. So we'll begin the discussion with the case. Case goes like this. It's a 60-year-old gentleman presents to emergency with a history of black-colored vomitus and stools. Known case of acute coronary artery disease on dual antiplatelet therapy. Is tachypneic, is tachycardic, he's in shock, and obviously he'll be anxious. And this is not an uncommon scenario in ICU. How should we go about? So there are various questions that do arise when we deal with such patients. Should I intubate or assess his hemodynamic status first and correct it? Or should I place a rails to watch for ongoing bleed? Or arrange for immediate endoscopy, call gastroenterologist in the middle of the night and schedule a scopy? Or should we arrange blood? Should we start him on octreotide, terlipressin? How about antiplatelets he's on? And is there any role of proton pump inhibitors? Okay. So going back with this case, should I intubate this patient? So clearly, this case was a bit anxious, so he was able to maintain his airway. So primarily for this case, I don't think we should be going ahead with intubation. And what do the guidelines say? So there's nothing like prophylactic intubation here. In case by any chance you have intubated the patient, try and extubate the patient immediately post procedure. Intubate only if the airway is compromised, the patient is severely agitated, or there is ongoing active hematemesis. The first and the foremost thing what we are supposed to do is assess the hemodynamic status. It is the microcirculation that needs to be addressed before we go ahead with anything like scopy or transfusion or anything for that matter. Okay, prompt replacement with crystalloids, like sir just mentioned, like the trend is now crystalloids, preferably the balanced salt solutions. Initially with the fluid boluses, depending on the amount of blood loss, and there later maybe you can use up the dynamic tools to assess fluid responsiveness and transfuse. Okay, the primary goal here is to prevent multi-organ failure. This preventing patient ending up with a multi-organ failure is going to save the patient and save many more lives. And like any other patient, we end up usually giving more fluids in critical care. Try and probably titrate your fluids, because overloading again is more dangerous with respect to lungs and infection and other many reasons for that. So what are the risks this patient is carrying? What are the possibilities that he'll bleed or he'll have a re-intervention again requiring? So there's something like Glasgow Blatchford score which has been published. There are many tools for that matter. Glasgow Blatchford is one of the validated tool. It takes into consideration of patient hemoglobin, urea, blood pressure, and other parameters such as pulse, melena, syncope, hepatic disease, and cardiac failure. A score of anything less than 1 patient can be managed on an outpatient basis. Okay, and anything more 6 or more has got as a probability of 50% risk of needing intervention. So any patient coming to us probably has to be or needs to be classified for the risk stratification. Okay. For the same patient, should I place a Ryle's tube and give him a gastric lavage? This is again one of the common scenarios in ICUs. We end up putting Ryle's tube just to monitor if there's any ongoing bleed into the stomach that can be drained out through the Ryle's tube, or there's a probability that we end up giving gastric lavage. So what does the guideline say? So there is no strong recommendation for placing a Ryle's tube for any patient coming with a GI bleed. Okay, because it does not differentiate upper and lower GI bleed as such. And it failed to accurately predict the presence of a high-risk lesion requiring endoscopic therapy. So it couldn't predict anything. Okay. And it adds to the discomfort of the patient, like it adds to the pain, nasal bleeding, or failure of NGT placement. Sometimes the patient is in encephalopathy, your Ryle's tube might end up in his lungs. Okay. Because there is no evidence, probably need not overdo anything over here. And there is no observed differences in rebleeding rates or mortality. So clearly, no need of placing a Ryle's tube. Should we transfuse blood here? These, what are the guidelines being put forth, do apply for many of the critical care patients. Okay. If generally the consensus is hemoglobin of less than 7, we transfuse. Transfusion trigger is about 7 grams. If there is no cardiovascular disease associated. If there is a history of acute or chronic cardiovascular disease or patient is in shock, multi-organ failure, the transfusion trigger can be slightly higher, that is about 8 grams. We transfuse targeting about 10 grams. This holds good for all the patients in ICU for that matter. So there is thrombocytopenia. Again, the concern, most of the patients might have associated chronic liver disease where you see platelet counts being around 40,000 or 50,000 or little maybe less than that. But the guidelines do say if platelet counts of 20,000, you can clearly or safely go ahead with procedures like scopy. But if there is anything planned like biopsy or any intervention is being planned, target platelet count of 50,000, it can be a little tricky in a resource limited setup, but definitely this is a guideline where probably we can stick on at least to the count of 50,000. Okay. So should I start this patient on octreotide or any vasoactive agent? The guidelines definitely are against use of any vasoactive agents like octreotide because the source of bleed is what we are assuming is non-varicose, where there is no role of any vasoactive agents. And sometimes if the patient is unstable, these can be more counterproductive. And definitely patient probably will assume he's come in about 12 in the midnight. Should I wake up my gastroenterologist and send an ambulance for an emergency endoscopy? So emergent endoscopy is about within 6 hours, urgent is 12 hours. Should we go ahead, disturb him? What the guidelines say, what we practice? Okay. So there is definitely no role of emergent or early scopy. So the case is all yours. Whatever patient coming with GI bleed belongs to the critical care team before the gastroenterologist comes into action. Okay. For next 12 to 24 hours is your patient. You have to revive him, resuscitate him, then schedule him for a scopy. Then only the role of a gastroenterologist comes. Okay. The early or emergent endoscopy has proven to be more harmful to the patient. Okay. So the emergent endoscopy. The early endoscopy, that is within 24 hours, has shown lower in hospital mortality, shorter length of stay, lower total hospital costs. Okay. Urgent, definitely don't plan, and it adds to the mortality. So post-scopy, post-endoscopy, like say it is past about say 12-16 hours, you stabilize the patient, taken him for the planned scopy. The source of bleed can be classified depending on the what is the etiology or the cause of bleed. So this can be differentiated into staged into 1A, 1B, 2A, 2BC depending on the probability of rebleeding or the risk of rebleeding. 1A, B are the spurting bleed or a oozing bleed that are seen from the ulcer beds. 2A is a non-bleeding visible vessel And 2B is adherent clot that you can see. Adherent clot, and 2C is a flat spot and ulcer, and 3 is a clean base ulcer. So 1A, B and 2A carry a maximum risk of rebleeding chances where you'll have to be more cautious, more vigilant. So we'll have to classify the patients based on the endoscopic features, because you can prognosticate or plan rescopies or keep the blood products or resuscitation measures standby. So what about the antiplatelets the patient is on? The patient here was on dual antiplatelet therapy because the patients ending up, or most of them are on some of the other antiplatelets. These days, your antiplatelets, DOACs, the usage is, as the survival has increased, the usage of drugs also have been increased. Aspirin monotherapy for a primary prophylaxis, definitely we'll go with the. So wherever there's a high risk of endoscopy stigma that has been diagnosed, like 1AB, 2AB, okay, the patient is on low dose aspirin for primary prophylaxis. There is no underlying cardiovascular disease here. It is just purely for a primary prophylaxis. Okay, continue to withhold low dose aspirin. Here you can stop aspirin for time being, because here it's a primary prophylaxis. Patient doesn't have any underlying cardiovascular disease as such. If the patient is on a secondary prophylaxis, definitely you should continue low dose aspirin without interruption. Aspirin need not be stopped because it probably increases the risk of stent thrombosis or thrombotic episodes. Okay. Patient on dual antiplatelet therapy, continue low dose aspirin without interruption. Probably the second antiplatelets can be stopped temporarily. And try to reinitiate within 5 days, as the platelets turnaround time is about 5 to 6 days. They will have new platelets. Try to reinitiate the antiplatelets by then. Okay. In case of low risk stigmata patients, like I said, 2C and 3, where you need not have to stop the antiplatelets in either of the patients. And what about DOACs? You can stop DOACs as they have a relatively shorter half-life of 8 to 12 hours. It can be safely stopped. In case there is a life-threatening bleeding or a shock, ongoing bleeding, the prothrombin concentrates can help in reversal. And there are reversal agents available, like reversal with idarucimab for and andexanate can be safely used, and we can reverse the medicines within a couple of minutes where it is really urgent. Vitamin K antagonists are again routinely seen. Vitamin K can be used. Vitamin K will take maybe a couple of hours to reverse the vitamin K antagonist effect. In emergency or life-threatening bleed, we can use PCCs or FFPs. And for the want of correction of INR or coagulopathy, do not delay endoscopic hemostasis. Probably both can go hand in hand. And with respect to INR, there is no clear, there are guidelines with respect to the amount of the INR that is anything more than around 2.5 can be safely taken up for procedures. Okay. And for varicose bleed, definitely there is no so far consensus with respect to the INR. So do not delay endoscopic hemostasis with the want of normalizing the numbers what you are encountering with the patient. Okay. We just discussed this. So coming to the endoscopic interventions, the high-risk endoscopic stigmata, that is F1A, B and F2A, perform endoscopic hemostasis. Combination therapies of using dilute epinephrine with a second hemostasis, that is thermal, mechanical or sclerosant agent injection, can be performed. If there is F2A stigmata, like thermal, mechanical or sclerosant injection as a monotherapy or in combination with dilute epinephrine injection can be planned. If there is a F2B, there is a adherent clot, consider performing clot removal followed by endoscopic hemostasis of underlying high-risk stigmata, or medical management with high-dose PPI with continuous infusions for about 72 hours can be planned. If clot removal or endoscopic hemostasis is performed, dilute epinephrine injection circumferential to the base of clot followed by clot removal using cold polyp snare or Guliton techniques. It's more of an endoscopic or a gastroenterologist perspectives. Okay. Patients with actively bleeding ulcers, combination therapy using epinephrine injection plus a second hemostasis modality can be tried, like you can see in the picture. There is epinephrine injections is being planned about the ulcer base and around the ulcers. You can also use the modalities of clipping for similar patients wherever the visible blood vessels are there. Okay. In case the bleeding is refractory to all modalities, very rarely you encounter such patients also. We can plan for transcatheter angiographic embolization, schedule the patient for embolization as early as possible. And in case you don't have option for TAE, surgery can be scheduled. Okay, what about the proton pump inhibitors? What does the evidence say? Yeah, the guideline says the high dose PPI infusions for about 72 hours or you can use the high dose proton pump inhibitors twice daily is also acceptable. Okay. Post endoscopic management, PPI infusion for about 72 hours or high dose PPI, and there is nothing like redo scopy. You can risk stratify the patient and schedule scopy in required patients, say about 4 to 5 days later. Okay, if there is recurrent bleed, we discussed, we can consider embolization. And in all the patients, try and identify for the H. pylori infection, which is again a common reason for the GI bleed, and treat it. Thank you.